Hey you, it's me again. Let's carry on with our series Floating Over the Bone Marrow. Today we will be brushing upon a new topic, Megaloblastic Anemia, and also learn some new things related to it. Megaloblastic Anemia. It is a defect in the DNA synthesis which is causing ineffective erythropoiesis. Okay, so we'll see the causes. B12 deficiency, folate deficiency, usage of antifolate drugs like that of methotrexate, refractory to B12 and folic acid treatment, okay, MDS and AML, drugs interfering with the DNA synthesis, that is the cytarabine. Then we have 6-MP, azathioprine, hydroxyurea. Orotic aciduria, we will see how it causes the B12 deficiency, and thiamine responsive megaloblastic anemia. So this is a new word, right? Also we have seen that there is a predisposition of blood group A to megaloblastic anemia, and the genetic factors like that of HLA-B8, B12, BW15 and 3. So we have three types of B12. We have ado B12, we have methyl B12 and we have hydroxo B12. Hydroxy B12 is very easy. On exposure to the light, the hydroxy B12 is synthesized, or we get ado B12 and methyl B12 from it. And we have ado B12 which is located in the mitochondria. It acts as a cofactor for coenzyme mutase, okay, and this is actually a reaction, okay. From methylmalonyl coenzyme to succinylcholine coenzyme, we need this enzyme, coenzyme mutase, and it acts as a cofactor for the coenzyme mutase, okay, located in mitochondria. Then we have methyl B12, which is located in the lumen, which is located in the plasma, in the cell cytoplasm. Now, it is important in methionine synthesis. How do we remember this? So, M for M, methyl B12, methionine synthesis. Ado B12, how do we remember this? A, coenzyme A, okay. Then this is the notes which I had prepared during my NEET PG entrance. The simple one, the basic ones. So it is a B12 deficiency anemia, cyanocobalamin, right? Daily requirement is 5 to 10 microgram per day. So we get B12 only in meat, fish or dairy products. So when vegans, we say the decrease in B12, right? B12 levels are low. So of course in a diet we have B12, and then in the stomach it is entering with the help of heptocorrin which is produced by the salivary gland. In the duodenum, the heptocorrin is removed by the pancreatic protease, and in the parietal cells, with the help of the parietal cells, we have intrinsic factor. In the ileum, we have tubulin receptor. So this heptocorrin is now, whenever it comes towards the parietal cell in the stomach, so heptocorrin is released and the parietal cell secrete the intrinsic factor, and the B12 gets attached to it. Then in the ileum we have a tubulin receptors. So the ileum is the maximum site of absorption for B12, and it is transferred by the transcobalamin 2. We also have 1, so we'll see the difference between 1 and 2, right, in some meantime. Okay, so those tubulin receptors, these are present in two cells. This is the yolk sac and then proximal tubular epithelium. Okay, so remember this, proximal tubular epithelium and yolk sac, we have the tubulin receptors. Okay. Intrinsic factor, chromosome 11q13, can be asked in super speciality or in certain big grounds. Okay, 11q13. Then causes. So causes are very easy: poverty, vegans, okay, increased demand, puberty, pregnancy, lactation, and impaired absorption, malabsorption syndrome, gastrectomy, pancreatitis, ileal resection. So the most common worm which is associated is the fish tapeworm, Diphalobothrum latum, or in iron deficiency it was the hookworm. Just revising it. Okay. So this reaction I have made a cycle, so you will remember it. Just remember that the DNA synthesis, okay, whatever DNA synthesis is happening, so whenever there is a B12 deficiency, so that will cause decrease in DNA synthesis and maturation arrest. So there would be a pancytopenia, that means everything will be decreased, okay, everything will be low. Then homocysteine to methionine we need B12, and homocysteine, whenever there is rise in homocysteine, it will cause thrombosis picture, right? And again the methylmalonyl coenzyme to succinate coenzyme we have already seen in the last slide. Methylmalonyl coenzyme, succinate coenzyme, so that is required for the myelin sheath, and if the myelination is not done, so there will be neurological degeneration, is called as subacute combined degeneration, SCD. So clinically we have pallor, fatigue, infections, splenomegaly, jaundice, neurological degeneration, subacute combined degeneration. Everything will be low, pancytopenia picture, right? MCV raised, MCHC raised, MCH raised, okay. So remember, whenever a patient comes to you with a pancytopenia picture and who is middle aged, like 25 or 30 or so, then we ask about his addictions, and then we get to know that he is a chronic alcoholic, right? And this alcohol is major factor seen in, at least in the government setup, for the pancytopenia picture. Of course there are other features of the other causes of pancytopenia, but then why am I saying this? Because we need to add, always remember, if it is an alcoholic patient, chronic alcoholic patient, just add folic acid 5 milligram, okay. And of course we have the Vitcofol injection, so we can also so because of the Vitcofol itself, patient will improve. That's why I'm saying it, okay. So in the peripheral smear we have a macrovillosize, that is the earliest picture which is seen, and then we have a Cabot rings. We will be seeing one by one what are these and how do they look, okay. So just remember, Cabot rings are the remnant of mitotic spindle. Hypersegmented neutrophils, we all know that. Oval-Joly bodies, it is a remnant of DNA, and a basophilic stippling, which is a fine basophilic stippling, which is a RNA fragment. So basophilic stippling is a RNA fragment, Oval-Joly body is a DNA fragment, and mitotic spindle then Cabot ring. Okay. Now you can also remember these things with the help of like mitotic, Cabot, okay, like that you can remember. Oval basophilic stiffening RNA, like that you can remember. Coarse basophilic stiffening is seen in sideroblastic anemia. So what is the definition of a hypersegmented neutrophil? So neutrophils with 6 or more lobes, or more than 3% neutrophils with 5 or more lobes. Okay. So neutrophil with 6 or more lobe, one neutrophil it's okay, and if it is more than 3% neutrophil with 5 or more, that is hypersegmented neutrophil. There will be of course erythroid hyperplasia. Bone marrow will try to compensate for the pancytopenia picture whichever happening. The NC ratio, it is normally it is 3:1, and it will be a reversal of NC ratio because the cytoplasm will be a big one because of the maturation defect. Then the megaloblasts are large erythroid precursors, like we said that there will be erythroid hyperplasia and there will be sieve-like chromatin. So the serum methylmalonyl coenzyme, serum homocysteine, B12 assay is decreased. So then we have this folic acid deficiency, which is mostly absorption is occurring in the jejunum. And the neurological complications are not associated with folic acid. It is the B12 which is causing the neurological complications. So folic acid is present in liver, yeast, green leafy vegetables and nuts, unlike that of B12. So 250 microgram daily should be administered. RDA is around 100 and 400 in females. Okay. So it is better that folic acid is being constituted in female at the time of conception itself, and up to that of the term pregnancy we give her folic acid. So the pernicious anemia, it is a type 2 hypersensitive reaction, and there is a type 1, type 2 and type 3. Type 1, which is the in which there is a blocking which is occurring between B12 and intrinsic factor. Then the B12 and intrinsic factor, this complex is not binding to the ileal receptors, that is actually the type 2, and type 3 is antipyridals and antibodies. So there would be beefy tongue, atrophic glossitis, then associated autoimmune Hashimoto's thyroiditis, or we have DM, and there will be increase in risk of gastric adenocarcinoma. So there would be, whenever we see the biopsy picture, there will be infiltrate of plasma cells and lymphocytes which contain excess of CD4 cells. Okay, this can be a potential MCQ. CD4 cell, okay, plasma cells and lymphocytes. Okay. So this is the hypersegmented neutrophil, okay, and the big macroovulocytes. Remember, hypersegmented neutrophil is nothing but 6 or more lobes, or more than 3% of the cells have 5 or more lobes. That is the diagnostic criteria for hypersegmented neutrophil. So this B12 and folic acid, both of them undergo enterohepatic circulation. Now, because of this enterohepatic circulation, if any person has a malabsorption syndrome, then we will have severe kind of deficiency as compared to that of even vegans, because vegans will have that enterohepatic circulation intact. Okay, so if malabsorption, B12 more rapidly rather than that of the vegans. Now we have transcobalamin 1 and 2. The difference between both, these are all, both of them are transport proteins for B12. Transcobalamin 1, 11q chromosome, transcobalamin 2, 22q chromosome. It is synthesized from the neutrophil granules. Now this is from the liver, endothelium, macrophages, okay, ileum. 2/3 is the saturated, okay, no tissue delivery. This transcobalamin 2 is the most important for the tissue delivery, okay, to the placenta, to the bone marrow, okay, other tissues. Now there is a clathrin mediated endocytosis associated by a megalin, okay. So this, remember this gene, CRP2 gene exported by ABC-MRP1. This is responsible for the resistance in the elderly persons. So we have seen, or we will be seeing, or we have already seen, whatever. We have already seen the elderly person have little less response to that of chemotherapy. This is because of this ABC-MRP1 gene. Okay, clathrin mediated endocytosis which is associated. Then it is removed. This is the transcobalamin 1 is removed by the glycoprotein receptors excreted in the bile. So in this slide, the important part is clathrin mediated endocytosis associated with that of transcobalamin 2, ABC MRP1 gene and CRP2 gene. Okay. The transcobalamin 1 is secreted from the neutrophil granules, and mostly it is the transcobalamin 2 which will be transporting the B12 part to the bone marrow or to the tissues, and it is secreted by, transcobalamin 2 is secreted by the macrophages, epithelial cell, then the endothelium, then the liver and ileum. So MRP1 is responsible for the drug resistance elderly leukemic patients, so that they are less responsive to the chemotherapy. Folic acid B9, it is yellowish in color, crystalline, water soluble. So it differs from the natural folates. How does it differ? It is reduced from dihydrofolate to tetrahydrofolate, contains a single carbon unit, and 70 to 90% are in polyglutamate. So whatever we eat, these are polyglutamate forms. So it needs to be broken down into a monoglutamate for the absorption to take place. So this is the folates which are present in the food, and in the intestine, this is hydrolyzed to monoglutamates. Okay, so intestinal mucosa, we have this 5-MTHF. Then with the help of the proton coupled folate transport, it transports the 5-MTHF at low pH. This is important, that low pH across the apical brush border of intestine because of the proton coupled transporter, okay, folate transporter. In the liver, it undergoes the intrahepatic circulation and folic acid in the plasma is received, and then there is cellular uptake of it. Now 1/3 is bound to the albumin and 2/3 is free. Then it is present in the breast milk, in the CSF and in bile. Okay. So this is the cycle. Cycle says we have a more polyglutamate, intestine, monoglutamate, then 5-MTHF, it is in the intestine, and proton coupled folate transport, low pH, liver, and then enterohepatic circulation, then cellular uptake to the different tissues. Then the cellular transport via the folic acid binding proteins. This is the RFC SLC19A1. So this is important, SLC19A1. We have a disorder associated with it, and FR2, FR3 GPI anchored proteins. So these are the folic acid binding protein. Now the biochemical reactions, so involving various forms of folate. Okay. Now in the pyrimidine synthesis, we have 5,10 methylene tetrahydrofolate. In the purine synthesis, that is 10 formyl tetrahydrofolate. Okay. Now pyrimidine synthesis, remember bada naam, bada coenzyme. So pyrimidine 5,10 methylene, 10 formyl purine. Okay. 5,10 10. This is the rate limiting step in the DNA synthesis, pyrimidine. Okay. And then in purine synthesis, need for DNA and RNA synthesis, then format activation, generation of 10 formyl THF. So the most important thing here over here is pyrimidine synthesis, 5,10 methyl THF, and that is important step in the DNA synthesis, rate limiting step. Now this is the cycle, starting with a homocysteine. We have already seen to homocysteine to methionine we need B12, right? So there is this methylcobalamin, and along with it we have methionine synthesis, because 5-MTHF that has been broken down from the polyglutamate to monoglutamate gets transported into a tetrahydrofolate form. Okay, because of this reaction only methionine synthesis, and we have the B12. Along with it, homocysteine is also getting transferred in methionine, and then we have the methionine, we have the SAM. Okay, not going into the biochemistry of it, SAM into SACH, and this gives the methyl donor, okay, in various reactions. Then the tetrahydrofolate form is received, okay, and it is responsible in the purine synthesis. So it will be the 10 formyl tetrahydrofolate, okay, and we have the formate. So that will be responsible for the 10 formyl tetrahydrofolate. So from the tetrahydrofolate, because of certain format or adding of the format, so there will be 10 formyl tetrahydrofolate formation, and this tetrahydrofolate formation is responsible for the purine synthesis. We have already seen 10 THF, right? 5-10 pyrimidine. Then this 5-10 we have seen, this is pyrimidine. Okay. Again this 5-10 going into tetrahydrofolate, okay, dihydrofolate form. This is actually received that whenever we have a folic acid, okay, it will go into a dihydrofolate form, and because of the hydrofolate reductase, it will get converted into a tetrahydrofolate form. Okay. Along with it, we have a deoxyuridine monophosphate into deoxythymidine monophosphate that is being converted along with it. So this is the whole cycle. In this whole cycle, remember this part, okay, this into this is very important part, this into this is also very important, okay. Both these two things are very important, other things we have already covered in this reactions. Then the dihydrofolate reductase, we would be aware of these things, methotrexate, pyrimethamine and trimethoprim. This is the inhibitor for dihydrofolate reductase. So we can say these are the antifolate, right? For methotrexate rescue, we always use the folinic acid, or we have the citrovorin factor or leucovorin. Now this leucovorin is used in colorectal cancer. It enhances the 5-fluorouracil by increasing the binding of the drug to thymidylate synthase. Okay, so that's why it is used in methotrexate rescue. Remember 3 important names: citrovorin factor, folinic acid, leucovorin. Then coming to certain congenital diseases, we have a congenital intrinsic factor deficiency. Now in this, it is an autosomal recessive inheritance. It is mostly seen in first, third year of the life. There it is the biopsy says they have a normal gastric mucosa and normal HCl secretions, but the antiparietal cell and antienzyme factors are absent. Okay, so there is congenital intrinsic factor deficiency. So autosomal recessive, first, third year, normal mucosa and antiparietal and the anti intrinsic factor will be absent. Now, what are the deficiency? So first is the malabsorption, then we have the gastric causes, and then we have the intestine causes. In malabsorption, we know pernicious. Then gastric causes, whatever gastrectomy and all that. So partial gastrectomy, congenital absence of intrinsic factor. Intestine causes, we have numerous of them. Intestinal stagnant loop syndrome, jejunal diverticulosis, ileocolic fistula, anatomic blind loop, intestinal stricture, ileal resection, Crohn's disease, tropical sprue, transcobalamin 2 deficiency, and diphyllobothromblatum of fish type 1. So, B12 malabsorption but not severe enough. So, the gastric causes for it. So, whenever there is a gastritis associated, or we have Zolling-Ellison syndrome, or users of PPIs, proton pump inhibitors, okay, and also we have this gastric bypass, bariatric surgery. So, that can cause malabsorption, that can cause B12 deficiency, but not very severe enough. Again, we in the intestinal causes, we have the HIV, radiations, okay, then gluten-induced enteropathy, severe pancreatitis, graft versus host disease, okay. Then deficiency of cobalamin, folate, riboflavin, nicotinic acid. These four can cause megaloblastic anemia. Okay, remember this. Riboflavin is also important. Nicotinic. Now add MBBC. Okay. Then treatment with, remember, colchicine. Okay, cytotoxic drugs, CC, anticonvulsant drugs, okay, alcohol, metformin, MN, neomycin, okay, and PAS. So these are the drugs which are associated with megaloblastic anemia. Now metformin, why metformin? How does it act? It causes decrease in transcobalamin 2 levels. Very important. Does not hamper with the absorption. It is actually the transcobalamin 2 levels are decreased. So cytotoxic drugs, alcohol, anticonvulsant drugs, colchicine, PAS, neomycin, metformin. Okay. Certain drugs need to be remembered. Then in the anesthesists and dental students and the dentists, the N2O metabolism. Okay. So it oxidizes the methyl B12 to an inactive precursor which inactivates the methionine synthesis, and methionine synthesis is very important. We know that, we have seen in the cycle. So this is seen mostly in the dentists because they use N2O. In severe pancreatitis, the calcium level decreases and there is lack of trypsin. Okay. So why severe pancreatitis is causing megaloblastic anemia? Then we have pernicious anemia. Okay. We all know the basic part: pyloric gastritis, H. pylori infection, serum gastrin levels raised, pepsinogen levels decreased, antrum is paired. Okay. Chief cells secrete pepsinogen, which is decreased. Gastrin levels is increased because of the antral G cells. Okay, compensatory increase. Then we have the parietal cell, which is secreting intercell, which is decreased, and intrinsic factor is also decreased because of the parietal cell. Okay. So antiparietal. So we have two type of antibodies. We have antiparietal cell and we have the anti-intrinsic factor. Antiparietal cell is sensitive, but intrinsic factor is a specificist. Okay. So there is one disease, juvenile pernicious anemia. As the name suggests, juvenile, early age, okay, older children, but early, older than that of congenital. Okay. There would be now juvenile pernicious anemia. Pernicious name suggests there would be certain abnormalities in the biopsy. Okay. There would be achlorhydria, there would be atrophic glossitis. Okay. There will be a gastric atrophy, serum intrinsic factor antibodies, antiparietal cell antibodies are absent, but remember this, no role of antiparietal cell antibody in juvenile pernicious anemia. Then 50% will obviously have concomitant autoimmune whatever diseases like DM or thyroiditis. So that was juvenile pernicious anemia. Then we have congenital B12 malabsorption or Imerslund-Grasbach syndrome, or we have autosomal recessive megaloblastic anemia. So this is also an autosomal recessive, just like that with congenital intrinsic factor deficiency. It is the most common cause of megaloblastic due to B12 deficiency in infancy. What? Imerslund-Grasbach syndrome. So there is actually this tubulin receptor. So this tubulin receptor and the AMN mutation. So tubulin receptor mutation and AMN mutation. So we have selective B12 deficiency. Along with that, we have proteinuria. Now, why? We already have learned tubulin receptors are present in the yolk sac and in proximal epithelium, right? So, proximal tubular epithelium, so there will be proteinuria associated and B12 deficiency. This is the tubulin receptor mutation. Also, there will be normal gastric mucosa, normal HCl secretion, intrinsic factor normal, everything is normal. Okay? There is just a mutation which is present in tubulin. Okay? And renal biopsy will do because of the proteinuria. We will not get any cause for it. Then we need to see if the B12 levels, or we need to first of all identify MCV and MCH. And then peripheral smear, we will see the macrovalocytes and everything, and then we'll come dhire dhire to the diagnosis. Then congenital transcobalamin 2 deficiency. This is the megaloblastic anemia within the few weeks itself of the birth, and there will be megaloblastic anemia, there will be reduced immunoglobulin, neurological abnormalities are seen in transcobalamin 2. Serum B12 levels and folic acid levels are normal. They respond to massive injections of B12, 1 milligram thrice weekly. Genetic abnormalities include the intraexonic cryptic splice site, extensive deletion, single nucleotide deletion, nonsense mutation, RNA editing defect. So, congenital transcobalamin, neurological abnormality, reduced immunoglobulin. Okay, remember this. Then congenital methylmalonic acidemia and acidemia. Acidemia, the name suggests that this would be a serious problem, right? Acidosis, failure to thrive. Okay. So there is actually either defect in methylmalonic coenzyme mutase, as the name suggests, methylmalonic acidemia, or its cofactor adocobalamin. So symptoms are from the birth itself. Infants have vomiting, failure to thrive, metabolic acidosis, ketosis, mental retardation. There will be normocytic normochromic anemia. So why is there normocytic normochromic anemia, not a megaloblastic anemia? So because of the B12 deficiency, there is a macrocytic anemia, but the succinate coenzyme is decreased because the methylmalonic coenzyme is not getting converted into succinate coenzyme because of the B12 deficiency, and the succinate coenzyme is used up in heme synthesis. Okay? So there won't be any hemoglobin formation. So there will be microcytic as well as macrocytic picture, and that will be nullified, and then we have a normocytic normoblastic picture. So if ADO B12 deficiency respond to the high doses of B12, decrease in succinate coenzyme, there is actually decrease in heme production. Okay. Thiamine response to megaloblastic anemia or Rogers syndrome. It is also an autosomal recessive in Henderson. Remember, we have already discussed SLC19AC gene, which is present on chromosome 1q23. So that is a responsible defect which is responsible for the thiamine response or Rogers syndrome. Now, the thiamine receptors, where are they? They are present in the bone marrow, pancreatic B cells, subset of cochlear cells. So, because they are just present in the cochlear cells, we have a sensorineural hearing loss. Then we have the pancreatic B cells involved, so that will be causing DM, and bone marrow, that will cause megaloblastic anemia. So, megaloblastic anemia, DM, sensorineural hearing loss. Thiamine is very important for the Krebs cycle to function well and ribose pentose pathway. So, if thiamine is deficient, succinate coenzyme not used up for the heme synthesis, less heme synthesis, that means the iron not used for the heme, and the iron gets accumulates, and there is a sideroblast which is present. Okay, sideroblast, ring sideroblast, we say the iron gets deposited like this, and there will be ring sideroblast or sideroblast for that matter in thiamine responsive or Rogers syndrome. Okay. So there is this DID mode, that means diabetes insipidus, diabetes mellitus, optic atrophy, and deafness. Deafness is because of sensorineural hearing loss, and then diabetes mellitus, and then we have the megaloblastic anemia. Remember thiamine receptors. Tubulin receptor was Amos-Leng-Resbach syndrome, most common important megaloblastic in infancy, and Rogers syndrome, thiamine responsive. Then we have orotic aciduria, deficit in de novo pyrimidine synthesis, defect in UMP synthase, and is also an autosomal recessive accumulation of orotic acid. There will be severe megaloblastic anemia plus the growth retardation, but there is no hyperammonemia. So related to pyrimidine, orotic aciduria, pyrimidine synthesis. Then we have folate deficiency. So proton coupled folate transporter we have seen in the intestine. It is transferring this pi MTHF. So causing folic acid deficiency and folic acid transport in CSF. So there will be also CNS features. Okay. Drugs causing folic acid malabsorption, sulfasalazine, cholestyramine, triamterene. In case of dihydrofolate reductase, it was the trimethoprim. Okay. And then in case of the drugs causing folic acid malabsorption, sulfasalazine, cholestyramine, triamterene. Folic acid is easily removed from the plasma by dialysis. This is a fact. Okay? So folic acid is being easily removed. So what do we know? We need to give prophylaxis to these patients who are on long term dialysis or chronic dialysis patient. Okay? So this is a table from Harrison, causes of folate deficiency. So dietary, we know old age, alcoholism, poverty, okay, and psychiatric illnesses, malabsorption, tropical sprue, gluten enteropathy, dermatitis herpetiformis, okay, then Crohn's, Whipple's, partial gastrectomy, jejunal resection, the drugs sulfasalazine, bacterial infection, lymphoma, then excess utilization or loss. Physiologic, we have the pregnancy, lactation. Hematological causes, chronic hemolytic anemia, sickle cell anemia, thalassemia major. Then malignancy, carcinoma, lymphoma, leukemia, inflammatory Crohn's disease, tuberculosis, psoriasis, metabolic homocystinuria. Excess urinary loss, congestive heart failure, active liver disease. The antifolate drugs, that is the anticonvulsant drugs, sulfasalazine, tetracycline, and mixed causes, that is liver disease, alcoholism, intensive care, curates. The symptoms of megaloblastic anemia, they can be asymptomatic, anemia, fatigue, weight loss, diarrhea or constipation, unconjugated jaundice because of increase in the bilirubin, hyperpigmentation which is reversible, there will be leukopenia, there will be thrombocytopenia which is worsened by that of the vitamin C deficiency, alcohol and malabsorption, impaired bactericidal function of phagocyte. So all the features are well known to us, but the leukopenia, thrombocytopenia and impaired bactericidal function of phagocyte, this is new and this is very important. So B12 deficiency affects all the lineages and phagocytes. That's why leukopenia, thrombocytopenia and phagocytes function is not well. Along with osteoporosis, demyelination symptoms. So there will be neuropathy. The posterior column is involved and the pyramidal tract is involved. There will be ataxic gait, there will be spasticity, autonomic disturbances like hypotension, impotence, incontinence. Cranial nerves are involved, causing optic atrophy and anosmia. No methylation of biogenic amines like dopamine. So the neurotransmitter dopamine is not there. That will cause Parkinson's-like symptoms. Neuropsychiatric like cognitive impairment and dementia. On MRI, we have a spongy degeneration of the spinal cord. Now, epithelium. Epithelium is the second most common organ after hematological bone marrow involvement. There will be macrocytosis, there will be multinucleate cells, dying cells. It is the lining which is involved respiratory tract, urinary tract, ठीक है, female genital tract. In pregnancy, it will lead to prematurity, fetal losses, neural tube defects, ठीक है, neural tube defects, anencephaly, meningomyelocele, spina bifida. So neural tube defect is reduced by 70% if we are supplementing folic acid. Other association, that is the polymorphism, okay, and we have cleft lip and cleft palate along with the neural tube defect. Now vascular events are because of increase in homocysteine that will cause thrombosis. So both arterial and venous events, so there would be strokes, increased risk of strokes. Malignancy, the folic acid prophylaxis in pregnancy decreases the childhood acute lymphocytic leukemia. MTHFR C677T polymorphism has a negative association with that of MLL leukemias. There is low risk of colorectal cancer, and the same one is directly proportional hyperdiploid infant acute lymphoblastic leukemia, childhood AML, childhood ALL. So other cancers, breast cancer, stomach cancer, follicular lymphoma. Now, if it is an established tumor, do not give folic acid because it feeds on it. Okay, so it will help tumor will get to grow more if we are supplementing folic acid. Then chromosomal changes. There would be in porphyrin tissues, bone marrow precursors will be seen, then transformed lymphocytes. There would be random chromosomal break, then centromere spreading over prominent satellites. Ineffective erythropoiesis is a feature of hemolysis. Bone marrow says Banau, or there is indirect bilirubin is raised, urine urobilinogen is raised, haptoglobin is decreased, LDH is increased. There will be positive urine hemosiderin. Now, hematological disorders says folic acid deficiency is seen in chronic hemolytic anemia, sickle cell disease, autoimmune, that is hemolytic anemia, congenital spherocytosis, myelofibrosis, and malignancies. So, B12 levels, with the help of ELISA, we will be discovering that there will be deficiency which will be less than that of the 100. Normally, it should be 200 to 1000. Now, also low B12 levels are seen in, remember this, FOTM. What is it? Folic acid deficiency, B12 level is decreased, we all know that. Transcobalamin 1 deficiency, ossiples, and multiple myeloma. Okay? So in case of folic acid, in case of ossiples, in case of transcobalamin 1 deficiency, multiple myeloma, there would be decreased B12 levels. Increase in case of cancers like breast, liver, pancreas. Also, homocysteine levels is increased in smoking, alcoholic, CKD patients on pyridoxine, steroids, cyclosporin, hypothyroidism. We have a holotranscobalamin assay. This is the active fraction of B12. So it is normally 35 to 171. If it is less than that of the 32, there is deficiency. In pregnancy and in OC pill users, B12 levels drop physiologically, but holotranscobalamin is not affected. So it is a physiological drop in case of pregnancy and in case of OC pills. Folic acid levels, it is usually 2 to 10. LSI technique, with the help of LSI technique, we will be studying the folic acid levels. Now, even in the recent diet, okay, they will low even in the recent diet. Okay. Now, serum folic acid levels are increased. B12 deficiency blocks the conversion on the MTHF to THF, tetrahydrofolate. Okay, that is the methyl folate trap. We have already seen this many times, folic acid deficiency. So serum folate levels is increased in severe cobalamin deficiency due to block of conversion. This is also in intestinal stagnant loop syndrome. We have already seen B12 deficiency is present. Then we have something which is RBC folate levels. So this is normally it is 160 to 640, and it is not affected or very less affected by dietary changes and hemolysis. But whenever we have a blood transfusion, or there will be recent transfusion, or we have high retic count or hemolysis. So there will be falsely it can cause that it is a normal, it is the levels may be in normal, showing the RBC folate levels are normal. So it is normal, it is 160 to 640. Okay. Prophylaxis: CKD patient, pregnancy patient, gastrectomy, ileal resection, long term treatment with PPIs. Now with the treatment, there is leukopenia, there is thrombocytopenia, there are phagocytes which are affected, but with treatment there is thrombocytosis seen. So consider aspirin whenever it is more than that of the 8 lakh. Also there will be hypokalemia, so we need to look after that. Now we have various B12 formulations. So we have cyano B12, we have hydroxo B12, methyl B12, ado B12. So natural forms are available for hydroxo, methyl and ado B12. Back to coenzyme is only for methyl and ado. Conversion steps 4300. Remember 4300. Sustained release is very good for hydroxo. Remember this because they are released, right? We have already seen on the first they are released like this. So very good. Okay. And we know that the detoxification of hydroxo B12 is required in the DNA, brain, nerves, blood, methyl B12 present. For the energy purpose in the brain, in the muscles, we have ado B12. This is not very important, but these four are very important. This, remember, hydroxo getting hydrolyzed, okay, or you say they're getting divided because of exposure to the light. So it is nice, very good sustained release. Conversion step 4-3, cyano, then hydroxo, 4-3. Then the bioactive form only for methyl and ado. Then we have the natural form which is for uh, hydroxo, methyl and ado. So coming to the treatment part. In USA, it is the hydroxo B12 which is more commonly used. Now, it is 1000 microgram intramuscularly given. Now, it is given for 3 to 7 days, okay, at the interval of 3 to 7 days. For almost 6 injections should be given. Maintenance on every 3 months, we need to call the patient. Now, if the patient is with a neuropathy, alternate day we need to be given, and then 2 months for the maintenance, okay. Oral and sublingual formulations are available, that is hydroxo B12. For the folic acid, normally it is 5 milligram which is required, okay, daily for 4 months, except in the pregnancy which is given from the time of the conception to that of the term or till the baby is delivered. In malabsorption, 15 milligram daily for 4 months, okay. So 4 month picture we need to remember. 6 injections in hydroxo B12, and that too 3 to 7 days interval, and maintenance for 3 months. For the correction of neurological manifestation, first use B12 and then we need to give the folic acid. Folic acid prophylaxis: dialysis patient, parenteral feeds, pregnancy 400 microgram, past history of neurotube defects 5 milligram per day, and if premature babies, that is less than 1.5, 1 milligram daily. Prophylactic folic acid decreases the homocysteine levels to prevent the cardiovascular disease. And remember, cobalamin is solely synthesized by microorganisms. So I hope you have all enjoyed this topic. Thank you so much for watching.